Good evening. I'm going to be talking on management of stage 3 non-small cell lung cancer, evidence and experience so far. This has been made possible by AstraZeneca, to whom I would like to express my gratitude. These are my disclosures. Just a quick summary. I'm going to be talking about the definition and incidence and treatment history of stage 3, the immune checkpoint inhibitor concept, 5-year update of the Pacific study, the role of the multidisciplinary team in stage 3 non-small cell, the issues of sequential versus concurrent chemoradiation in the context of durvalumab, the uses of durvalumab in cases with a druggable driver mutation, and the management of pneumonitis and other immune-related adverse events. So this audience is very likely familiar with stage 3. The precise definitions of the TNM categories are changed every couple of years. This is the 8th edition. If you count them, there are 39 different T and N combinations of within the broad stage 3 category. So I can't go into all of it, but it's not the early resectable ones. It's not the widely metastatic ones. It's those that are kind of in between. And what it usually involves is mediastinal and or supranavicular lymphadenopathy. That's kind of the majority of them that we see in the clinic, or tumors that are very close to or involving vital structures in the center of the chest. So stage 3 is about 25% of non-small cell lung cancer, so it's a major public health problem. The long-term survival and cure rate is depicted on the screen. And it is somewhere around 20%, 15–20%. The major advance occurred in the early 1990s with the addition of chemotherapy to radiation, and this has improved the median survival. If you look at a meta-analysis, the actual improvement is not that much, but there are different studies that actually indicate that the results are a bit better if you use the right chemotherapy than this meta-analysis shows. Initially, we used sequential chemoradiation with platinum-based chemotherapy prior to radiation and then radiation alone. But subsequently, it was found that if you use concurrent chemotherapy, concurrent platinum-based chemotherapy especially, together with radical intent radiation, that you get a better result. But again, from this meta-analysis, the effect is clearly there, but it is not a very large effect. Nonetheless, the ESMO guidelines do appreciate that some patients are not fit enough for concurrent chemotherapy and radiation. Some are elderly, some are frail, some have not optimal performance status, and some have very large tumors. And so sequential chemoradiation is appreciated that it could be an option in some people. And in fact, the original Dillman study, which established the utility of platinum-based chemotherapy in stage 3, was in fact a sequential study and published in the New England Journal of Medicine in 1990, showing actually a very large incremental benefit in median survival of about 4 months, and actually pushing up the tail of the curve. So the cure rate ultimately increased almost to about 20%. Nonetheless, it has also long been appreciated that concurrent chemotherapy and radiation is associated with a higher incidence of grade 3 esophagitis especially. And this can be somewhere between 20 and 40%, and may not be tolerable by elderly, frail people, especially if they don't have people to care for them. Sequential chemoradiation has a much lower toxicity with grade 3 esophagitis of about 4%, and so it is clearly much more tolerable. The modern meta-analysis has indicated that 5-year overall survival with concurrent chemoradiation is about 15%. It's about 10, almost 11% with sequential. So clearly, although we're curing some people, if this were breast cancer, it'd be completely unacceptable, for example. But there's still a long way to go. And this has been the impetus for lots and lots of trials that have tried various strategies and tactics to improve the situation, such as, for example, as seen here with consolidation platinum-based chemotherapy, which was not effective in improving PFS or overall survival. And the same is true of consolidation docetaxel. That didn't work either. Putting up the dose of the radiotherapy from 60 to 74 gray actually was worse. It's actually more harmful. So we certainly don't do that. Other things have been tried, such as various vaccination strategies, changing chemotherapy to pemetrexed in the non-squamous, which shows more equal outcome and less toxicity, but is certainly not better. So until recently, the standard of care was to do the chemo radiation, either sequential or concurrent, and then patients were just put on active surveillance, and most of these people relapsed, and most of them relapsed systemically. Certainly, the surgeons have attempted to see if they can make a difference to these outcomes. So this is exemplified in this particular study and in other studies. In this case, N2 patients with stage 3A really were randomized to platinum etoposide and 45 gray. And at that point, there'd be a pause, they'd be reassessed. If there was no progression, the group randomized to surgery would go ahead to surgery. The group randomized to completion radiation would go ahead to receive 61 gray, and then they both have a bit more chemo at the end. This graph shows that, in fact, there was no overall benefit from this strategy of doing surgery, which is the yellow arm there, and the blue arm is the chemo radiation. There certainly was a suggestion that patients who might be treated with a lobectomy might benefit from surgery, whereas people who had to have a pneumonectomy might be harmed. So this curve is a little bit complex. It seems to be a composite of some people who have benefited and some people who are harmed. But overall, I think, and this is actually depicted in this next slide here, this is a hypothetical analysis, but I want to stress that the blue data there is actually fictitious. The yellow data is actual data of people who had the particular surgery, either lobectomy or pneumonectomy. But the supposition, and looking carefully at the staging, was that those patients on the radiation alone arm, but who might have had a lobectomy if they'd had surgery, might have been improved by having the surgery, whereas those who would have had to have had a pneumonectomy were in fact harmed, or could have been harmed. So a little bit of a lingering confusion about really what is the role of surgery in stage 3, particularly in stage 3A, and especially single station N2, which we'll talk about. One thing we learned from this intergroup study was that surgery does improve local control. So the incidence of local only failure came down from about 20 to about 10%. So that's an achievement of surgery, and I think we have to understand and acknowledge that. However, unfortunately, most of the recurrences were systemic, and the surgery had no significant impact on the systemic failure rate. So it's partially helpful, but it certainly doesn't solve the major problem. What about, as I've said, single station N2? Well, the results are certainly better with surgery compared to multiple N2, but at best they're only mediocre. You know, this is 40%, 43% 5-year survival is really not very good. And you know, even the best of the best, which is the single station upper mediastinum N2, they're only really surviving at just over 50%. And you know, although this is, you know, not bad for lung cancer, you know, looking at the history of it, it's not good, and it's not something that we should be satisfied with. And this is further illustrated by this very large study from South Korea, where just under 600 patients were treated with trimodality therapy, chemoradiation surgery. Most of them were single station N2. It was kind of the best of the best. And in fact, the progression-free survival at 5 years was only just under 30%. So that's not great, even in these very selected patients. And of the most patients recurred, and of the recurrences, more than 80% are distant. They're not local, they're distant. There may be a local component, but they're certainly distant, with or without local failure. So unfortunately, we've had to conclude that doing the surgery, no matter how technically excellent, and we have technically very good surgeons, they're really trying to shut the barn door after the horse has bolted. Most of these patients have microscopic disease at presentation. We went through this paradigm with breast cancer a long time ago, and I think we'll have to relearn it with non-small cell lung cancer. So it's really a systemic disease in the vast majority of people. It's just that our staging machinery doesn't have the sensitivity to pick up microscopic disease. Now, with circulating tumor DNA, that may be a different story, and we'll see how that unfolds. But I want to talk about the different kind of thinking that we've had to adopt in order to address this problem. And this is around the antigenicity of these cancers, which are very often associated with smoking and are very mutated. So these cancers are turning over. They shed antigens all the time. These antigens are picked up by dendritic cells. They're trafficked to the local lymph node. They're presented to the T cells by the dendritic cells. There's a checkpoint there that's an inhibitory checkpoint called CTLA4, which was discovered by this individual, James Allison. And then if they can get around that checkpoint, they can then go back into the circulation in a clonal expansion situation and then get to the tumor where there's another checkpoint called the PD-1, PD-L1 axis. And that is another inhibitory checkpoint which can exhaust the T cells. And that was discovered by Tasuku Honjo, and both of these individuals deservedly got the Nobel Prize for Medicine. So what about radiation? So radiation is thought on balance to potentiate immunotherapy. It does many things that I don't have time to, but which are described on this slide here. But one of the things it does do is that it elevates the expression of these antigens at presentation by elevating MHC expression, which is on the surface of the cell, the cancer cell that is. It also blows up the tumor, so they shed more antigens. It results in the upregulation of and excretion of many cytokines into the tumor milieu, or what has been irradiated. But it also allows increased trafficking of immune and inflammatory cells into the tumor. And of course, if you don't have these T cells in there, you don't really get a good anti-tumor effect. But the one thing that it does do that can be antagonistic to the immune system is elevate and upregulate the expression of PD-L1. Now, chemotherapy can help the immune system as well by releasing and upregulating into the tumor cell a variety of proteins such as HMGB1, such as calretinins, and smaller molecules such as ATP. And all of these things, as well as exploding the tumor and making more antigens, can facilitate the functionality of these dendritic cells, which can then, being more mature and more capable of presenting antigens, can then scoop up these antigens and show them to the T cells. So chemotherapy has a role here to play as well, so-called immunogenic cell death. And these concepts, have been built in now to this specific study, because essentially what you have to do is you have to block this PD-L1 that's upregulated by radiation. You have to block it in some way, and durvalumab is an anti-PD-L1, so it can block it on the tumor cell, so it removes this inhibitory effect. Same thing on the dendritic cells or the macrophages that can inhibit the T cells, again through the PD-1, PD-L1 axis. You can block it at the level of PD-L1. So all of this was encompassed into the Pacific study, which we now have a 5-year update of, and this was a study, as you're well aware, which involved good performance status patients who had combined concurrent chemoradiation and who were then reassessed afterwards, showed not to have failed on treatment, and who were then randomized 2-to-1 to either durvalumab given every 2 weeks or placebo. And the co-primary endpoints were progression-free survival by a blinded committee and overall survival, as well as a raft of other outcomes and translational science. This is the spectrum of regimens that we used concurrently. I will emphasize some of these people did have, in addition, some induction chemotherapy. So you were allowed, if you felt it was necessary, either for reasons of getting the patient onto the machine and planning, or because you felt the need to shrink the tumor, people were allowed to have 1 or 2 cycles of platinum-based chemotherapy up front, and then they had to have combined chemoradiation, or you could just have chemoradiation by itself. But what you were not allowed to do was to have chemotherapy after the radiation and then go on to the study. So platinum vinca, platinum taxanes, but particularly platinum etoposide. This is now, the 5-year update's been published in the Journal of Clinical Oncology, and you can see now These curves split very quickly. They remain apart. They got further and further apart. And we have data now out to 60 months plus, where, of course, there's a lot of censoring. So we will have additional follow-up in the future, but certainly we have 5-year data that shows a very striking survival benefit, unlike all of these other strategies that we've employed for 30 years to try and shift the needle. Really, this is the only strategy that has really shifted the needle. And what we see here in terms of crude survival, there's an extra 10% of people are alive at 5 years who would not be alive otherwise. If you really want to know what the protection from cancer is, you see this from the progression-free survival curve out now at 60 months. Again, it splits early. There's only, if you look here, there's only about, maybe 15% of people who don't benefit because they come down together on that curve. Looks like 85% of people are deriving some kind of benefit, whether it's a prolongation of the time to failure, or they never fail at all. And if you look, it goes up from 19 to 33%. That's almost 1 in 6, 1 in 7 people has been protected from cancer. And I want to emphasize this, that it's protected especially from systemic failure, as well as local failure. But this curve shows the protection from distant disease. This is the time to distant metastases. And again, it splits early, it stays apart. These curves are very widely separated. You can see the median really has been doubled from 18 months to 36 months. And there's a really decent tail on the curve here, pushing it up from about 20 to 34%. So there's a huge protection here from distant metastatic disease, which we know is really lethal. And in most people, not everybody, but in most people, is a death sentence. We know that there's a protection in both smokers and, actually, interestingly, in people who are non-smokers. A bit of a surprise, but there it is. There even appears to be some level of protection in EGFR mutated patients, and that we see that in the progression-free survival as well. There was a bit of an issue initially about the PD-L1 negative patients. This was not a pre-planned analysis. The pre-planned analysis was greater or less than 25% PD-L1 expression. But there was concern initially that the hazard ratio may not be favorable in the PD-L1 negative patients. Now, I just make a couple of points around that. Firstly, if you look at the 5-year update, and the point estimate now is very, very close to 1, and there's very wide confidence intervals on either side of that. Why? Because the number of PD-L1 totally negative patients was really rather small, and this study was not powered around PD-L1 negativity. And so there's just statistical noise around that area. So I don't think you can say anything about the overall survival. But what you can say is that the progression-free survival seems to be fairly robustly in favor of exposure to development. So we in Canada, we have no problem paying for this drug in PD-L1 negative, PD-L1 positive patients, all of them. PD-L1 is not an exclusion criterion here in North America, and nor particularly in Canada, where we have a track record of being careful about how we spend money on new drugs. And also, if you push the needle this way or that way to get the biopsy, you can get a different PD-L1 result. And we know that with radiation, the PD-L1 goes up. So this is pre-radiation, baseline PD-L1 expression. It's not really indicative of what happens, once you've radiated the tumor. So we don't pay attention to the PD-L1 level when adjudicating who should get this drug. But it is important to show that people with cisplatin had a bit of a better benefit than people with carboplatin, although these confidence intervals overlap. And especially if you can get onto development within 14 days of completing radiation, there looks like to be a significantly better outcome than people who are on between day 14 and day 42. So we tell people that they're going to have this treatment. It's not a surprise. We get the CT scan pre-booked. We make sure that they know this is going to happen, and it's all smooth, and they get an early CT scan. And they get onto it quickly, if possible. Some people are beaten up and they need a bit of time, no question. But if you can, it's better to get it on sooner rather than later. The tumors continue to shrink more on the durvalumab than on the placebo. The complete and partial response rate continues to improve. And we know that symptom control is correlated really with tumor shrinkage. What about toxicity? Well, there's certainly radiation pneumonitis. You're going to get that either way. You get that in the placebo or in the development arm. So you're not going to escape from radiation pneumonitis risk, whatever you do. But there's a little bit of an increased pneumonitis rate on development, but most of it is grade 1, 2. It's mild and can be managed. It is very uncommon to have serious grade 3, 4 pneumonitis due to the development. I'm not saying it cannot happen. It can, and you have to watch for it, but it's not common. And usually if it occurs, it's mild. There's a bit of constipation. There's probably from hypothyroidism. There's a bit of a rash. There's some other mild side effects that can occur, but you have to familiarize yourself with immune side effects in general. This is certainly an immune checkpoint inhibitor, but it seems to be that the rate of toxicity we're seeing here in development versus placebo is very acceptable considering the magnitude of benefit. And again, you see any grade pneumonitis, whether it's radiation or whatever, is up from about 25 to about 34%. But mostly it's manageable and mostly it's mild and does not lead necessarily to discontinuation, except in about 1 in 20 people. So an additional 1 out of 20 people may discontinue because of development. So here is the protection. You can see there is massive protection, both from local failure in the lung and from the lymph nodal failure in mediastinum and brain, liver, bone, and adrenal. It's down by 1/3 to 1/2. So there's massive protection here compared to the just the surgery, no surgery, where there is no benefit in systemic failure. In the Pacific study, there's a lot of benefit, both local and systemic, including protection from brain metastases, protection of about 50%. That's down from about 12% to about 6%, and protection from liver mets. And we all know what the significance of that is. So the median survival is pushed up from about 30 to about 48 months. The progression-free survival goes up by about a year. The long-term data indicates that this is not just kind of delaying recurrence in some people. It's actually cure. It looks like these curves are flattening out now. It looks like we are curing an additional maybe 10 to 15% of patients. And this is a milestone, not only in medical oncology, this is a milestone in medicine and science. In the interest of time, I'm just going to scoot over that really quickly. There's a massive program on development, both in early stage resectable, in late metastatic, and in stage 3 that is ongoing. I just want to talk a little bit about concurrent versus sequential. This is a real world evidence study done in Europe and Australia. Patients were treated either with sequential or concurrent chemotherapy and then placed on development. The outcomes were followed. About 1 in 6, about just under 15% actually had sequential chemoradiation. I think that mimics my practice. Who was it who got sequential? Well, unsurprisingly, it's older people and it's people with bigger tumors. So this kind of fits in with what we know. There's a significant comorbidity, disease burden in these patients, hypertension, COPD, diabetes, obesity, and so on. And the PFS outcome, which was really not rigorously assessed as in the Pacific, was actually better than in the Pacific. I'm not saying that's true or not true. It's just that it may not have been assessed as rigorously as in a highly controlled randomized trial, but it's not less. It's not less. And if you look at the concurrent versus sequential, you can see that the outcome is very, very similar. So doing the sequential seems to be a reasonable strategy, if you feel you have to do it. It's probably better to go concurrent, but sequential's okay. And the toxicity here was pretty much the same as in the Pacific study. So I'm just going to give a case report or two real quick, and I know my time's running out. So there's a 75-year-old man who's had a stroke. He was worked up. He was found to have a small tumor in the lung, incidentally asymptomatic. He was actually had N2 nodes. There's these PET scans showing the primary, the hilar node, the N2 node. It's biopsied. It's a very poorly differentiated carcinoma. It's very strongly PD-L1 positive. There's no actionable mutation. He's assessed by medical oncology and by my colleagues in the MDT. He's treated with combined radical intent chemoradiation. We used cisplatin vinblastine. We had an etoposide shortage at that time. And we told them we're going to offer him development. We see that post-treatment, he's improved. He then goes through the development quite smoothly, no problems at all. He has a good 3 years. He then starts to see flashing lights in his visual field. He's got a brain met here at the occipital lobe. You can see here on the MRI. This is resected by surgery. It's now 1 to 49% PD-L1 positive. It has a P53. We thought, is this a different tumor? We searched him from head to foot, nothing else. This is very likely a recurrence. We thought about radiation. We decided to offer him SBRT to the cavity, tumor cavity. And we think, should we have offered him Development back in 2019 now, 3 years ago? And actually, he's 75 years old. But we know that people over the age of 70 have the same benefit as people under the age of 70. He has over the 70, under 70, benefits about the same. And this gentleman had a markedly delayed recurrence. So we think that he's one of these people who were protected to some extent from recurrence. He never had systemic recurrence, hasn't had it yet. He's been resected with a solitary delayed recurrence. We believe he had considerable protection from the DIRV, and we're happy that we actually did it. He's now been resected and the cavity is irradiated. He's now a curative intent candidate again. Critical role of the MDT. We know with the COVID-19 that fewer people are discussed on the MDT. You have to work to overcome this challenge. One way you can do it is with telemedicine, with technology. Here's a study from Philadelphia showing that even if you do this with patients, that there's no delay to get onto radiation. There's no delay to get onto chemotherapy. There's a bit of a delay to get onto surgery. So surgical intent patients may be better seen in person, but you really should have this core MDT, with the medical radiation surgical oncologist, a pulmonologist, a radiologist, critically important, a pathologist, critically important, and support staff. You can make this more sophisticated. You can have immuno boards. You can have genomic boards. You can have advanced radiation technology boards. You can have national and boards that look at difficult cases. That's all very nice, but you do need this core key component to discuss staging, invasive or not invasive staging, and the management plans, which are multidisciplinary, complex, heterogeneous, etc. We know that patients do better in academic centers. Why do they get better? Well, they get more exposed to up-to-date drugs. We know that they're exposed to people who are more knowledgeable. We can't expect community oncologists to know all about everything. So it's good now for patients, even out in the district, out in places like India and Canada, which are huge countries, where they can be patched in for an opinion from an MDT in an academic center. And we know this is good because if you look at the United States, 45,000 patients from SEER, if they have guideline concordant treatment, which only 23% of them had, they do better than those who got non-concordant. So it's better to be in front of an MDT. So driver mutations, and I'm just going to say one quick slide here. We know that KRAS, BRAF, and MET14 skipping benefit from immunotherapy. We know that HER2 mutations and EGFR mutations sometimes benefit from immunotherapy. ALK and ROS, maybe not. And this is shown, for example, in the IMpower 150 study, where the PFS, the response rate, was better in the EGFR mutated subset, albeit a small group of people. You can clearly see here, these curves are separated because of the exposure to atezolizumab versus just the BCP, Bev, platinum, paclitaxel chemo. So again, I'm just going to finish off to say that in the LAURA study, basically, this is stage 3 randomized to osimertinib or placebo. We don't have this data yet. It's an open question. And here's my last couple of slides. 52-year-old female from the Philippines living in Canada has a lump in her neck. There's the lump in her neck. There's her chest X-ray, the CT scan showing a hyalur mass. She's got an N2 node. This is the biopsy that clearly shows an acinus there in the cytology. TTF1 is positive. We staged the rest of her. It's all negative. The PD-L1 is 1 to 49. It's not negative. She's a never smoker, but the PD-L1 is 1 to 49. She has a sensitizing EGFR mutation, but she has chemoradiation. There's the baseline. There's the CT scan. She has cisplatin etoposide and 60 gray standard of care. And we then talk to her. What we're going to do, here's a CAT scan. She's not progressed. She's clearly improved. We said, here's Development. We're prepared to do it. We're not funded for osimertinib. We don't have the data for osimertinib in the setting. We offered her Development. She took it. After 2 cycles, she got a little bit shorter breath. We looked at the CT scan. She's got clearly what looks like radiation pneumonitis because it's in the radiation field. The rest of the lungs look okay, but we decided to hold the Development just out of an abundance of caution. And so for 2 or 3 months, we put on a weaning dose of prednisone And she kind of, by September, it's about 3 months later, she felt better. This is obviously a radiation effect here. There's no evidence of disease progression. She went back on the nivolumab, and she's now had 8 cycles of nivolumab. She's tolerating it very well. And her intent and our intent is to take her through to completion. Just to say, there are some adverse events. You have to know how to deal with them, but they seem to be lower with pneumonitis with the PD-L1 as opposed to PD-1. I mean, that's a controversy, but this data package seems to suggest that pneumonitis with PD-L1, anti-PD-L1 is lower than PD-1, anti-PD-1, and lower than anti-CTLA-4. Grade 1, you can probably keep going. Grade 2, you're into oral steroids and holding the immune drug. Grade 3, you're into IV steroids like methylpred. And grade 4, you're certainly into hospital admission and oxygen and maybe even a ventilator. You don't want it to get down to grade 3, 4. So you need to be vigilant and you need to act, even if it's just radiation pneumonitis alone, because it could be. It's hard to know the difference. So this has been reported on and reviewed very nicely in this presentation, and anybody can have these slides through the company. Please feel free if you want these slides. We know that the key thing is conforming the radiation so they don't violate the V20 principles. And you do a CT scan, you see that sometimes it's in the radiation field, sometimes it's outside, where most of the disease is not. And the patchy pneumonitis, which can be organizing pneumonia, ground glass, or tree and bud. We know the Pacific study, as I've mentioned, had a reasonably low rate of pneumonitis, as did the real world evidence. And with that, I'm happy to end my presentation here. Thank you, Mr. Chairman, and the audience for your attention.
Thank you, Professor Vinccent. It's a very extensive deliberation on stage 3. Professor Vinccent, I have one question, a quick question, if you allow me.
Yeah.
Yeah. So you have mentioned that stage 3 is a systemic disease, and one slide of you clearly shows that there is an extensive microscopic disease. So aren't we delaying the systemic therapy if we are using after the radiation?
Well, I think that, with the shift of the median survival and the median progression-free survival, I think, some of these people are still relapsing, but they relapse later than they otherwise would have. And I think you're buying people time with disease control. And I think the psychological impact of that is huge on people. But it seems that there's been a tail on the curve, that it seems that we are genuinely eradicated because those curves are now parallel. They don't seem to be falling progressively anymore. It seems that some of these people, maybe 1 out of 6, 1 out of 7, has actually been cured as a result of immunotherapy. So I think you can get rid of it with the addition of immunotherapy in some people. Who knows what's going to happen between years 6 and 10? Okay, we don't have this data yet, but it's looking encouraging that these people may have been cured, but a lot of people have been benefited because the recurrence has been delayed. And I think that's a very important benefit because it's all about time, right? It's all about buying time.
Yeah, thank you, Professor. Thank you so much. So we shall move on to the next
Thank you, and goodbye. Enjoy the rest of your meeting. Thank you.
Thank you. Thank you, Professor.